one result of our work with DSRIP has been a change in emergency medicine physician approaches and understanding to our patients. That as their doctor in the emergency department, we're there not only to address their chief complaint that brought them into the emergency department, but then to also, again, look at the patient more holistically and consider everything from housing and housing insecurity to medication access to follow-up care, to address the underlying issues that may have brought the patient to the hospital and leaves them at risk for returning to the hospital. I sometimes use the metaphor of an iceberg when a patient presents to the emergency department, and they may come to the ED just saying that they're short of breath or they're having an asthma attack, and that's the little tip that we see above the water. But then underneath the water, it may turn out that they have lost their home nebulizer machine and they need that replaced, or that they're currently homeless and don't have access to some place to receive their treatments, or their PCP is retired and they don't have good follow-up, or they were lost to follow-up with the pulmonology clinic, or they just don't know who to call when they have an asthma exacerbation, and so they just call 911. So the idea of broadening our scope and seeing these patients not just as an individual with an isolated medical complaint, but as a sort of entire individual who has all of these sort of components that make up the cause for an emergency department visit.